Ladies and gentlemen, I'm honored to participate and would like to thank the President of the EFSS, Professor Gamal Sarur, Vice President Professor Yahya, and the Secretary General Professor Shalakani for the invitation to speak at the 26th Annual International Conference of the Egyptian Fertility and Sterility Society. The topic is office hysteroscopy serving women of all ages. I have no conflict of interest to declare. I do participate actively in the activities of a few international organizations like FIGO and the International Federation of Fertility Societies, apart from being a consultant, full-time consultant in the Rotunda Hospital and academically linked to the College of Surgeons in Ireland. The hospital I work in, the Rotunda Hospital, is on its current grounds for a long time. This is a art piece from 1792, which shows the rotunda in the middle and towards its side, the two engines, as I like to call them. They are the Gate Theatre and the Ambassador Theatre. As the founder of our maternity, a man midwife, had the foresight to understand that you require finances in order to support the activities of a newly formed maternity hospital. So he provided entertainment for the reach of the time and used the money to care for women in pregnancy, in labor, and for women and their children after delivery. This is how the rotunda looks today, truly unchanged after more than 250 years. I have three learning objectives for today: indications for hysteroscopy, the two choices that both practitioners and patients have to make, and the challenges and opportunities when one practices outpatient hysteroscopy. You will all be familiar with the main indications for hysteroscopy, namely the assessment of the cervical canal and uterine cavity, treatment of intracervical and intrauterine pathology, and the diagnosis of malignant endometrial disease. So, as I said, for women of all ages, I would like to present when to refer for premenopausal and postmenopausal women. Without say, premenopausal women, the investigation of infertility is one of the main indications. Both cervical and endometrial polyps, intramural or submucosal fibroids, or suspected uterine anomaly. Women in the premenopause also suffer with menorrhagia, but also with intermenstrual bleeding. For the postmenopausal group, main indication is postmenopausal bleeding, particularly in women that don't have HRT medication. And also the unusual but not infrequent finding of a thick endometrium on transvaginal ultrasound performed for other reasons. The referral process is crucial in deciding if somebody is suitable for an outpatient hysteroscopy or not. Letters nowadays are mainly electronic. They will be from the general practitioner, the hospital services like the emergency room or the gyneclinics, and also need to state the clear indication for the procedure and what is the suspected pathology. At the same time, the person performing this procedure needs to decide if the patient is suitable for an outpatient intervention. Patient's age, if she's pre or postmenopausal, a previous pregnancy or not, a previous vaginal delivery or not, if known pathology is present or not. Furthermore, if the patient has certain significant risk factors like heart and respiratory disease or gross obesity, and the degree of urgency of referral. There is no doubt in anybody's mind that there is a constant shift from general anesthesia to no anesthesia. from inpatient to outpatient, from hospital bed occupancy to no bed needed, and may I say, from surgeon-focused care to patient-focused care. Yet, there are certain differences, and I can understand why one offers comfort versus the other. Patients that are seen in the setting of a hospital and assessed have the opportunity for intervention, for example, the GnRH injections to shrink a fibroid. They are seen before, they're prepared. They receive inpatient care. If you see a patient for the first time in the outpatient hysteroscopy clinic, there has been sometimes no previous diagnosis. Sometimes there's a good indication, a polyp or a fibroid was seen. There was no opportunity to shrink a fibroid. It is a first view, and it is a see and treat approach. But we have to accept that we must give our patients a choice of being an inpatient, receive general anesthesia, have a prolonged recovery, take time off work, versus outpatient, no anesthesia, no general anesthesia, local anesthesia for operative procedures, no time off work apart from the day of procedure, and limited anesthesia and surgical risks. Hospitals also are starting to recognize the benefits in improving their efficient services. Outpatient surgery reduces outpatient waiting lists. Theaters, main theaters, can focus on major pathology. There are more beds available for surgery for these patients, and no recovery beds are needed. So, ladies and gentlemen, I will start with the premenopausal woman. In the infertile world, uterine anomalies identified will need to be addressed prior to proceeding with assisted reproduction or any form of fertility therapy. The Cochrane database, this study in 2015, looking at hysteroscopy for treating subfertility associated with suspected major uterine cavity abnormalities, suggested that a large benefit with a hysteroscopic removal of submucosal fibroids for improving the chance of clinical pregnancy in women with otherwise unexplained infertility cannot be excluded. They suggested that more randomized trials are needed, yet it is very difficult to tell a woman where a pathology has been identified that all is well and she should proceed with treatment. Same study showed that if polyps are present, endometrial polyps are present, hysteroscopy and removal of the endometrial polyp improves pregnancy rates prior to IUI fourfold. There's no immediate evidence in relation to benefit prior to IVF. As you can see, the confidence interval crosses 1. Uterine fibroids, Garcini et al. In 181 patients, all subfertile, fibroids less than 4 centimeter, submucosal 94, divided in a study and control, and fibroid removal increased pregnancy rates after 12 months, nearly doubled the pregnancy rates. So how should we prepare our patients? Firstly, our patients need to receive a letter that details the visit, the procedure to be performed, and what she needs to do. For example, take analgesia, describe the medication, paracetamol and Nurofen. Bring urine for a pregnancy test. We do not want you to be pregnant if we're to investigate your uterine cavity. Have a full bladder. It helps in the situation where the uterus is anteverted to increase the cervical uterine angle and make the procedure smoother. And of course, cervical softeners like misoprostol in order to make the procedure and the access to the uterine cavity easier. This is the equipment that we have in our outpatient hysteroscopy. It starts from the far left with an ultrasound machine, then the camera, light, and monitor tower, then the operating tower here in front of you, and of course, and never forget this, an emergency trolley, because patients can have vasovagal reactions. The hysteroscopes, the diagnostic one, 1.9 millimeters, and the operative one, uh, which, as you can see there, connected to the camera as the operating channel. First, we identify the abnormality, and then we intervene surgically. And the tools that we use is this particular equipment produced by Hologic. It's called MyoSure, and you see there are three types of probes and a unit that drives this device. We are administering local anesthesia. We're using the same medication that is used for colposcopy. It has both analgesic properties, but also vasoconstrictive properties, so it reduces the amount of bleeding during dilatation and, of course, at the end of the local anesthesia administration. We normally inject at 3, 6, 9, and 12 o'clock. Wait a few minutes, use Hagar dilators to gain access to the cavity, prime the system, and then proceed. And what might we see? Well, you can observe here on the left-hand side polyps, intracavitary polyps, particularly this one, and following local anesthesia and cervical dilatation, we're blessed to have a very good picture in this particular case. And you will see in a moment the probe. You can see it has a blade that moves forward and backwards, and at the same time, the system aspirates the contents that are cut and washes everything internally. So you can see that even during the cutting of tissue, the image is very, very clear and allows you to identify the tissues. Now here the endometrium is quite polypoid, and I've insisted on doing a bit more than just removing 1 or 2 polyps, as you can see. The probe can be rotated fully 360 degrees. It's a very simple device, and it has a pedal which activates the cutting mechanism and at the same time the suction mechanism. May I just say that one big advantage of this particular technology is that no tissue remains in the uterine cavity, thus allowing you to constantly see what is left behind, what else do you need to remove. What about myomectomy? You might notice this is quite a large fibroid. None of these procedures have been prepped before. These patients do not have GnRH analog therapy. As long as there is space to introduce the probe around the fibroid, I carry on. There's a big difference between a polyp and a fibroid. You can easily see how hard this mass is, the wide structure of a myoma, and how difficult it is to eat it all in one. As opposed to the polyp where it all disappeared, the fibroid takes time. You will also notice there's very little bleeding from fibroids apart from the base when you reach the implantation site. I don't use any specific technique, but once I have lips like this one at 6 o'clock, I then tend to go in from underneath just to scoop that little lip. Fibroids on average take approximately 3-4 minutes depending on the size. I've used here a small diameter probe, although there is a larger diameter 22 for large fibroids, and that really works wonders in terms of speed of resecting the fibroid. Yet in this particular case, I didn't use that larger blade. These are unedited videos. I took them directly from the system just for didactic purposes. As you can see here, the fibroid is implanted or is attached very close to the right cornea. And this probe, although quite small, very difficult to fully resect into the corner of the uterus. What about the postmenopausal woman? For postmenopausal women, sometimes polyps are easily identified at the time of hysteroscopy. You can notice a very atrophic endometrium and a very small polyp there of no immediate consequence. And in such atrophic cases, it's very easy to remove these polyps. This device really takes them out within 30, 40 seconds. You can see the blood vessels there and how the pressure inside the cavity prevents the bleeding from these small vessels. One caveat is when tissue like that is present, it's not that easy to remove, as the device doesn't cut very, 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 very fine tissue extremely well. I'd like to share with you an interesting case. I always find that discussing one interesting case might allow you to learn something. And this is a lady that presented with postmenopausal bleeding, and ultrasound scan performed elsewhere showed an intracavitary fibroid. I'll start both videos. The one on the left is the initial assessment without the operative scope, and the one on the right is actually the procedure of resecting this fibroid. You can see on the left how the fibroid was located mainly towards the left side of the uterine cavity. Here, the ostia will come into view very soon. You can see it there, that's the left ostia. I'm going underneath the fibroid now. There is enough space for me to insert a probe and attempt to remove this fibroid in one single session. And you can see on the right-hand side, I'm already inside the uterine cavity. I've started resecting this fibroid. I normally go around and around and around till only a small root is visible. I do like to cut only when the image is very clear. You can see the big bites that this device takes out of the fibroid. So here, as opposed to the fibroid in the premenopausal lady, this fibroid was located in the left cornea. And again, some challenges here in terms of resecting the root of this fibroid. We're nearly towards the end of this video, and you can see I can't find a space there to insinuate my probe so I can cut the last part. But with a bit of perseverance and gently pressing onto the uterine wall, one might find a plane. It takes a bit of time. You'll see in a few moments how that plane opened up for me. Now, where I could just move the probe very gently. And now you have a very good grip on the fibroid, and one is able to finish this procedure. Cornea is a very thin area of the uterine cavity, and careful assessment needs to happen, and particularly once bleeding occurs, one needs to stop. So what happens with the sample? The sample is all aspirated through the tubing, arrives in this device on the left-hand side, and is collected. And you can see how we can scrape all this tissue and send it to the laboratory for histological analysis. And without any suspicion, histology surprised us. This lady had spindle cells with diffuse nuclear pleomorphism, frequent bizarre cells, and occasional multinucleated giant cells, and a likely diagnosis of leiomyosarcoma was made. The tissue was sent for immunohistochemistry, and this diagnosis was confirmed. She was referred immediately to the oncology services and had hysterectomy within a week afterwards. I would like to finish with a few remarks in relation to challenges, like poor view, and which can be adapted with either increasing the intracavity pressure or decreasing the suction. And this is one typical example where control of the bleeding was not very efficient. The equipment, sometimes the scope is not perfectly clean, sometimes the camera steams up, and there could be difficult cases like very challenging cervical dilatation to the level that the patient is uncomfortable and will require that the procedure is discontinued and a general anesthetic is considered. I'm still in the cervix here, but for a purpose of time, I'm now inside, and you can see while resecting this fibroid, the image will also be quite poor and not allowing me to see extremely well. Yet, with adjustment of the suction and intracavitary pressure, I could finish the procedure. There are numerous opportunities in relation to outpatient hysteroscopy. Both surgeons and the trainees develop skills. It provides a patient-focused service. It allows to train nurse practitioners, and it, of course, allows to certify any doctors and nurse practitioners. Ladies and gentlemen, I discussed with you a few care pathways for patients that require an outpatient hysteroscopy. I believe it's definitely the way forward. There's one visit, an assessment, and a treatment, all in one session. I've discussed with you the outpatient hysteroscopy services, the way are in our hospital, what we do and how we do it, a few tools and the learning process, and some challenges and opportunities. I would like to conclude that in my experience, outpatient hysteroscopy can be performed in over 90% of all patients requiring it, that adequate selection, preparation, equipment, and skills are needed, that such procedures are patient and hospital friendly for women of all ages, and outpatient hysteroscopy service provides an excellent opportunity to train and develop the next generation of gynecological surgeons. Once again, I'd like to thank the Egyptian Federation for inviting me and look forward to the discussion. Thank you.